Good morning, everyone. I want to thank, first of all, Dr. Srinivas for starting the concept of balance con. When I started practicing in this field, I had so many difficulties, but nobody to answer those queries. Now we have number of people, learned people with whom we can interact. Second, congratulations to Dr. Pradeep for holding such a wonderful thing. Common sense approach to vertigo. My colleagues who are into this field from last few years are very much aware that the basic standard of history taking, what we are taught, history taking and examination in a patient of vertigo, it goes haywire or it is not applicable as you progress in this field because of the multiplicity of presentations due to a variety of conditions. So you tend to devise your own ways, your own templates to approach a case of vertigo. So myself has started, I started right from basics, ABC, and I myself approach patient like this and will like to highlight that also in the stipulated time. Before that, I like to show you a few videos and then we'll comment on that. One day when I was in my OPD, I received a call from my mother at home. Beta, mujhe chakkar aa raha hai. I cannot stand. Can you come home? I rushed. And two things, I can't share all the videos. Have a look at the two videos. Yes, you had gaze evoked nystagmus. Yes, now it is clear. Gaze evoked towards right. And gaze evoked towards left. I did this cerebellar test. It was negative on the plus minus, but mostly it looks all right. Yes, it seems to be all right. Then after some time, I asked her to stand. And just have a look at it. This is truncal swaying or truncal instability she had. I asked which side you are falling, she said on the left side. Oh, just by narrowing the base of support, she tend to fall on the left side. Again, falling on that side. Yes. So, this is all. I immediately thought of the first impression was, although these tests were negative, first impression was cerebellar problem, age and hypertensive and all things. I called my sister-in-law's husband is neurosurgeon. I immediately called him. She said, "Koi dawa le rahi hai? Is she taking some medicine?" And then immediately something struck me. Oh my God. She is a patient of trigeminal neuralgia taking carbamazepine 1200 milligram from last 12 years. And recently she developed tinea for which she was put on antifungals. And then the things came clear that this is due to carbamazepine toxicity. I got her MRI done. It was all right. But I want to, this is one deduction from this video. Now I'll show you 2-3 videos and then we'll come to our topic. I want to go back, dear. it's all right. Then this patient.
दोबारा बैठ जा। एक मिनट का हाथ ना लाएं, खड़े हो जाओ एकदम से।
Yes, did you notice? It will be more clear after some time. I asked him, now it will be more clear here. I asked him to stand from a sitting position. What is this? Yes. Imbalance on standing from sitting position, and now he, yes, Valsar, this Romberg. With eyes closed, he cannot manage it. So this was from sitting to standing, and let us see his other position. This is, he is telling his history. I will skip it. Just see when he turns. Yes, that is the point I want to stress. Is somebody was talking of unilateral vestibular lesion, uncompensated. Yes, you have such a thing. This video was, he has ataxia, no doubt. This was a case of, this patient was started, tuberculosis was started on streptomycin, and after few injections, he developed this thing and was F. What I want, bilateral vestibular lesions, imbalance from sitting to standing, and on walking, and on suddenly turning, it gets exaggerated. Another, I have purposely not picked any BPPV or any vertigo thing. I have imbalance cases which are more difficult to and trickier to deduce. Now this is what I was talking of. This is history, I'll skip it. This patient presented with, he says, like this is where I wrote the history. And headache from 15 days, continuous, more on lying down. It was bitemporal, nothing, vertigo. It was more of imbalance and swaying. And on perturbations, I have drawn it. He used to fall on left and on anterior and obliquely. I'll like to show the perturbation which my colleague physiotherapist did on her. That is, she is doing perturbations. Nothing was there. Yeah, yes, this was the only position he was having imbalance when pushed from one side. No other examination was positive. Now, it was something disturbing. Patient says vertigo means imbalance. He has come with some problem, and it is bitemporal headache, but the symptoms, but something is normal person. Why should he try to fall? I got his MRI done, and it was acute occipital infarct. Acute occipital infarct he had developed. So what I want to stress is, any sort of infarct, occipital, parietal, or frontal lobe, I have all the videos, it can present with imbalance or something like that. Then this is another guy. Around, very interesting, around 1 year back, he developed vertigo, dizziness, went to a neurosurgeon or neurologist, got his MR angiography of the vertebral as well as cerebral arteries done perfectly normal, but that continued. He was a neurologist, the person who did it. 1 year back, he, while reading an article in newspaper, comes to me, and he was sitting in the chair, and I asked him, come close to me at the examination chair and just see when he gets up. So he is trying to explain what he feels like. Yes, yes. He is trying to explain how he walks and what problem he has. In the other video of the same patient, I asked him to go to the assistant. Yes, he is taking some time. Yes. Diagnosis was made. Diagnosis was made. Parkinson's. If at everything was all right, MRI, MR angios, MRI, cervical spine, and I sent the patient back to, I said, go back to that neurologist and ask him to treat you like a Parkinson's. And then came back, he was my junior during my college days also. He called me back that, yes, I missed it. You being neurologist should have diagnosed that 1 year earlier, dear. Now, this is a very interesting video, Dr. Alfargal. He is telling history and
दोबारा करके दिखाएं बैठ खड़ा रह
he is demonstrating how he gets vertigo.
बैठो तुसी बैठ के करो बैठ के भी आउणगे
Yes, yes.
अच्छा इवें किते आउंदे ने इवें ही रखी एक मिनट मैं रिकॉर्डिंग करनी इवें ही रख
लग गया जी हुन
आई जांदे यार
He says चक्कर आने लग गए. Vertigo has started.
नेरा हो गया जब मैं
हनेरा हो गया आंखों के आगे. Blackout has occurred. There were few nystagmus beats. Yes. So the point is, vertebral artery compression has to be tested, like Dr. Gans demonstrated at AIIMS Jodhpur. The way it has to be tested, the vertebral artery compression can occur. It does present, of course, and nystagmus on head turning. Cervical spondylitis was ruled out with that neck torsion test, but this is one which was suspected of having. He didn't go for MR angio, but these are the. He gets blackouts. I'm going. There are 3-4 videos, and this patient had the history of chiropractic done on his neck. So it was strongly suggestive of vertebral artery dissection. Last video. This is a very interesting video. This is a very interesting video and a lesson to be learned from it. My assistant physiotherapist was called one day, can you come at somebody's place and examine? She is having chakkar aa raha hai. She went there, called me that it looks like BPPV, we can correct it at his home also. I went there. The person says, now history. The person's my whole talk revolves around it. The person says, when I get up and start walking, I have vertigo. I said, I thought it was like BPPV. Like, I said, repeat it. So he says, when I get up and start walking, it is BPPV. It is the things revolve. But when I lie down, I'm comfortable. Now, this doesn't fit into the standard history of BPPV. So, I did all the examination bedside, what I could do. Nothing was apparent except this. So, I'll repeat it. Yes, get up. Yes, yes. This is enough. I can show more, but this is enough. What I want to say is, if history is not typical of BPPV, think of other things. I'll come to it during my talk. Last, very interesting video. I have shown it many times, but I'll for you, sir. People, for majority of the people, this is a carry home message. I've already said it in many places. For majority of the people, BPPV begins and ends also with Dick Salpike and play. No, you should do you should test all the canals before and after at least for canal conversion and after the testing. So this is a patient of canal conversion basically. I corrected his right posterior canal and see.
ओए भैया छोड़ दो, आप छोड़ दो ना जी, एक मिनट। ओए होए, ये तो हॉरिजॉन्टल कैनाल बन गई।
अभी देखते
ठहरो
रहिए।
अंकल जी, ठहरो।
Continue. I like this video very much. Yes. Horizontal canal is now dying down, and in the same year you get posterior canal. So lateral plus posterior canal, I have quite a number of cases of multi-canal BPPV, quite a number of them. But this is one of the most interesting videos. Now we start with our presentation. Common sense. If the common sense approach is, when you know the basics, what next? The theme of the conference is, you know the basics, what next? Next is think out of the box. Think out of the box. I'll start with balance, because working up a case of imbalance is more trickier than working up a case of vertigo, spinning sensation. Basic anatomy, basic balance of the body is made from by a tripod of information, from the sensory information from the proprioceptors, being the muscle spindle, the Golgi tendon organ, or the Pacinian corpuscles in the joint capsule, giving us the information of the joint sense or the position of various body parts in space through peripheral nerves, ascending tracts like spino-vestibular, spino-aurivally, spino-cerebellar, and other ascending tracts to various brainstem centers and cerebellum. That is one limb of the information. Second limb of the information coming from the semicircular canals, which judge the angular acceleration, linear acceleration, or the auto. But semicircular canals are gravity insensitive. Then how is the gravity judged? Line of gravity is judged by autolys. So that information coming from the eighth nerve to the vestibular nucleus, and visual information from eyes, vestibular nucleus judges it. Suppose I am walking down the ground, somebody calls me from behind, Sandeep! I immediately turn my head away. My vestibular system knows that I have moved my head. My proprioceptors told that body has not moved. Vestibular nucleus analyzes this and says that person is at the risk of falling. So it orders the vestibulospinal tracts to bring about the postural correction, and a fall is prevented. This is the vestibulospinal reflex. I won't talk of VOR at present. So this is how the balance of the body is maintained. Now, so the point is, what is motor control system? Motor control system is getting information from the three limbs, analyzed by this is a reflex arc. Reflex has a reflex arc, and the sensors or the receptors are the proprioceptors, the labyrinth, the eyes, and then the center afferent nerves, peripheral nerves, and ascending tracts being the afferent limb, center being the various brainstem nuclei, cerebellum, cerebral cortex, and then the efferent limb being the descending tracts, pyramidal and extrapyramidal, and the efferent organ being the muscles. But any movement of the body, whether it is voluntary or involuntary, is supervised, corrected by two supervisors, basal ganglia and cerebellum. So lesion anywhere in the motor control system, sensors, afferents, centers, efferents, effector organ, or supervisors can lead to imbalance. And that is why I say working up a case of imbalance is more trickier than a case of vertigo. So next is, so that means lesion anywhere can lead to imbalance. So we'll have to think from the basics. So let us see how various lesions which can lead to imbalance or drop attack. Suppose a patient of drop attack or fall comes to us, we'll have to examine all of these. Proprioception. Proprioceptors, sensors can be affected by peripheral neuropathy. I won't talk of joints. Peripheral neuropathy like diabetic sensory motor neuropathy, I have seen quite a number of cases presenting with imbalance or dizziness. Then peripheral neuropathy due to nutritional deficiencies. These are the common things which occur. Then afferent ascending tracts can get affected by something like transverse myelitis. I haven't seen any case, or something in the spinal cord. Then the sensors can be, then the other sensor is otolith. Normally giving us, when we are standing or supine, it gives the information that line of gravity is like this, and our anti-gravity muscles has a tone so that we don't fall. If it gives the wrong information, the tone is lost, and Tumarkin's otolith crisis. So lesion in the sensors or the afferents can lead to imbalance or that. And then in the one point, sir, Dr. Falgal, I like to ask you. I have seen a few cases who have had attacks of BPPV years back, around 2 years, 3 years back, but they say that chalta, when I'm walking, suddenly I used to fall like this. And occasionally. And few cases, 2 or 3 cases had a single history of single attack of like history of BPPV, and 2 or 3 others in which the BPPV like symptoms continued for some time. But why should they have these attacks? I like your comments about that after the talk, sir. Thank you. Next is center may be affected. Center may get affected, like Dr. Srinivas has given this, that when we are upright, when we are awake, our muscles are contracted and we do not fall, but if suddenly our muscle tone is lost, we fell down like in cataplexy, but I have been unable to see a single case. Various drugs, alcohol, anti-epileptics, anti-hypertensives, anti-epileptics, I started with an example of my mother. That can lead to drop attack, or it is many of the times difficult to differentiate between a drop attack and a fall. So we'll take it as one, that a patient comes with those attacks. So it can be due to syncope, of course, with a partial loss of consciousness. Then young children, epilepsy. Vestibular epilepsy, I don't know how common it is, but I am learning it. We are getting now regularly after consultation with Srinivas. Actually, what happened is that I used to do lots of BPPV, and these cases were quite rare and also didn't come to us. Now, since I've got VNG, and with all those findings and people referring the cases, now my diagnostic rate has decreased from 80 to around 50%. So that is why I constantly be in touch. I constantly remain in touch with him. And vestibular epilepsy is one thing which we are now getting regular EEGs done on, especially in young patients. That is one possibility. Vestibular epilepsy is usually present with quick spins, and it is not must to rule. In fact, majority of the times patient doesn't lose his consciousness unless until in 1/3 only it presents to tonic-clonic seizures. Otherwise, they doesn't lose their consciousness. Progressive supranuclear palsy, another interesting thing. He has put in my mind, and we have started working on that. Hummingbird sign and all those. We have started asking our radiologists on MRI. Then Parkinson's disease, I've shown a case of imbalance. Then multiple sclerosis, we all know, I won't go to explain each and everything. Multiple sclerosis at root and tree zone, multiple sclerosis affecting the ascending tract or descending zone, even a small. Then vertebral artery compression, I've already shown a case. Posterior circulation, TIAs these are all the things which can affect the central nervous system, center of the reflex arc. Then effectors can be affected, anti-gravity muscles can be affected by TIAs of the spinal cord or of the anterior cerebral artery. So, common causes being the Meniere disease associated balance-related fall, cataplexy, PSP, cardiac causes, and we have already mentioned them. So, this was about drop attack or fall attack. If a patient of drop attack comes to us, think on the lines of, on the pathophysiology. Similar, this was about the balance system. If a patient, now, does the gentamicin toxicity patient or the Parkinson's disease patient, they came with, not with vertigo, but with the imbalance. So again, the same pathophysiological mechanisms will hold true for that, but you can basically club them into three types of categories. One is peripheral neuropathy affecting the sensors, peripheral neuropathy or bilateral vestibulopathy. I won't tell how to diagnose a bilateral vestibulopathy. That is very easy. You all know HIT positive and other things, and I won't tell. And then peripheral neuropathy, how to examine, do a tuning fork test or other things. That is, examination is my question is to what should come in our mind when the patient presents to us. Third is, if there is no peripheral neuropathy, if there is no bilateral vestibulopathy, then we are left with the neurological gait disorders. Neurological gait disorders like Arnold Cherry malformation, again, we are very much, we are getting more number of MRIs done now. As like Dr. Manoj said, in every case we are getting done if we cannot diagnose clearly at the first go. Cerebral small vessel disease, it is very common. It is very common. Dr. Manoj will comment on it. In number of elderly people, you find small infarcts everywhere. But what is their significant? When to take them as significant, sir, please do mention and clarify the things. Parkinsonism, progressive supranuclear palsy, normal pressure, hydrocephalus, yes. How to rule out it? Tumors of the CP angle, cerebellar disease, wernicke's encephalopathy, again a new thing, sir was also mentioning, Dr. Alfargal. And how to, we have to be aware of all the, we diagnosed 1 or 2 cases of wernicke's encephalopathy. I diagnosed with the help of Dr. Shri Nivas. Okay. So, conditions which does not strike us immediately in a case of imbalance are cervical spondylitis and migraine. We don't think of these. Cervical spondylitis does not, sir, I will take around 2-3 minutes more. So cervical spondylitis does not present with vertigo, but the only presentation, like in branded book he has written, is unsteadiness of gait or ataxia. And one should be aware of it. Swaying, sway, I won't go into the swaying. Positional vertigo, I have already said. How to differentiate from central vertigo or migraine can lead to it. Vestibular epilepsy, you have quick spins. Vestibular paroxysmia, uncompensated UVL will present, like I've already said, on motion-induced dizziness. Vertebral artery compression, postural hypotension, Arnold Cherry's. So these all can present for positional vertigo lasting for few seconds. Acute attack, I will skip this slide. Prolonged episode, I will skip this slide. I like to mention few points. Common sense says that when vestibular system is involved, dizziness is not always rotatory. It is rotatory only when one side is involved more than the other. It can present with imbalance, like in bilateral vestibular lesion or in central vestibular lesion, or the vestibular lesions can be presenting, as Dr. Bijlani mentioned, is wholly solely as oscillopsia or motion-induced dizziness. On the contrary, everything which rotates may not be vestibular, like in purely cerebellar lesions or in case of epilepsy. Last thing is duration. First attack may be confusing. A case of BPPV with first attack lasting hours, many a times, and after patient will complain that the first attack lasted 3 hours, but after that he is having those typical attacks of BPPV. You delve deep into the history, he will tell no. You ask him specifically, and then he will clarify the thing that it was not a single attack, but it was multiple attacks occurring repeatedly for 3 continuous hours on the first attack. Seconds, BPPV lasting for seconds, not all, the vertigo lasting for seconds, not always BPPV, it can be due to vestibular paroxysmia or vestibular epilepsy. Again, I'll skip the rest. Precipitating factors, menstruation, sleep deprivation, etc. In migraine, if I see 20 cases of migraine-related vertigo, I have seen quite a number of children also with migraine, a big benign recurrent vertigo of children, which they say. Classical symptoms are in 1 or 2 in 20. Exaggerated by menstruation or sleep deprivation, etc. Episodic, repeated if it is episodic, repeated, that means some stimulus is always there, BPPV, migraine, cross compression, psychogenic factors. Well, again, whether it is cause or effect. Think on this. Common sense says that, again, vestibular plus cochlear, if both are involved, lesion has to be in the labyrinth or 8th nerve, or then they get separated. Then only thing is internal labyrinth and artery or ICA. Think on those lines. Blackout or loss of consciousness, think of vascular causes. That's all. Thank you. Thank you, sir.